I'd like to welcome all of you to a Longwoods leadership discussion. At some point in our lives, everybody here will either be a patient, be a caregiver, be a loved one with somebody with some form of cancer. Today, we're here to discuss some of those cancers and the innovations and different ways of treatment and how we're moving forward with those. To lead us through today's discussion, I would like to welcome a friend of Longwoods, a good friend of Longwoods, Fred Horne. Fred, the show is all yours.
Thanks very much, Matt. Hello, everyone, and thank you very much to Longwoods for the invitation to moderate today's session. Over the past 30 years, groundbreaking innovations have saved and transformed thousands of lives of Canadians with cancer. Immunotherapies and precision medicines in particular have made huge strides for many cancer types, including lung, prostate, and melanoma, sometimes turning a diagnosis people dread into something that requires less invasive treatments. That said, some types of cancer are far more difficult to treat. They're particularly aggressive. They're very hard to eradicate. And these include cancers such as rare lung tumors, glioblastoma, as well as pancreatic, liver, and gynecological cancers. Other countries have dedicated research programs for hard-to-treat cancers, while the world's top medical centers are developing new diagnostics and medicines, often using tried-and-true therapeutics combined with new treatments. The question we want to explore today is, what can Canadian researchers, clinicians, cancer agencies, and patient leaders do differently to shift the survival curves and to help cancer patients live longer and, of course, with a better quality of life? And to help us explore this topic today, we're joined by a very distinguished panel. Anita Angelini is Vice Chair of Brain Cancer Canada. Dr. Barbara Ann Millar is a radiation oncologist at Princess Margaret Hospital in the University Health Network. Robert Bick, Bob Bick, CanCertainty co-lead and co-founder and Kidney Cancer Canada board member. Bob, thank you for being here. And Rodney Ouellette, founder and senior scientist at the Atlantic Cancer Research Institute. Thank you to you all of you for making time today. So again, just Matt mentioned the Q&A function at the bottom of the screen. I'm going to be doing my best to monitor that. And we'll try to get as many of your questions as possible to our panelists. We're going to begin with sort of a guided discussion that we prepared for you today, and I'll be posing questions to each of our panelists. And, you know, as usual, we want to really try to understand this from a people perspective, the perspective of patient's family. And to do that, Anita has agreed to help us. Anita, if you wouldn't mind, telling us a bit about your husband's experience with a difficult to treat cancer, specifically glioblastoma, and the kind of challenges that you faced in getting the appropriate care and treatment.
Thank you so much. I'd like to start just with an expression of gratitude to Longwoods, to the other panelists, to everybody that's here today in the webinar as participants. I'm really looking forward to this conversation and honored to be included in it. I wear two hats in this conversation today, that of a spouse who has lost her husband to glioblastoma, and that as Vice Chair at Brain Cancer Canada. Just a little bit of background, if you're not familiar, Brain Cancer Canada, we fund research. We're a national organization and 100% volunteer. We're volunteer because we want to maximize the impact of every single dollar raised. We fund research, neurosurgical technologies, and we advocate for effective treatment of primary malignant brain tumors, pediatric and adult. Three areas of focus, I would say, for us ongoing, and it'll surface in this conversation today, is giving patients and their loved ones access to drugs, access to multiple forms of treatment, so not just drugs, but other kinds of treatment, and to make sure that across communities in Canada that we actually have the availability of neurosurgical specialists, technologies, and care, and there are gaps there. When I speak today, I'm speaking from the experience of glioblastoma with my husband, Filippo. But I want to acknowledge that this conversation has another level to it, which is all hard to treat diseases are in a very similar experience. So my husband was diagnosed with glioblastoma in 2019. He passed away in 2020. The conversation today is a little harder for me, I'm going to admit, because the anniversary of his passing is tomorrow, and the anniversary of his birthday is the day after. So it weighs on me. I think the overall theme that I want to express, and this comes not only from me, but from a number of my now very dear friends and colleagues that I know in the brain cancer community, which is that we need a fighting chance. And a lot of us don't feel like we had a fighting chance. And that's not to diminish at all the extraordinary efforts that have been made and the extraordinary people who are involved. But I think we really need to look at the options, and putting patients at the center of care. And there are a bunch of different nuances to that. But I'll start with, in our experience, when my husband was diagnosed and going through all the things that we went through, when we were in ICU, I was told, you are part of our rounds and you are part of the team, and you will come and meet with us every morning, and you have voice and you have agency and you can ask questions. And at that point, it felt very, very patient-centered. But ongoing, the burden was mine to dive into the literature, to dive into the research, to become informed, and to bring questions back like, what other forms of therapy might there be? Are there clinical trials? What can we access in Canada? What can we access elsewhere? And the information wasn't always shared. So it wasn't until much, much later that I started to learn about things like special authorization, special compassionate access to drugs and therapies, those kinds of things that start to make a real difference when you're going through the disease and its progression. We were in a particular circumstance where I had discovered in my research that there was something called novel optune TTF fields, that a treatment that was available, a non-invasive alternate therapy that was available in the US at the time. And we had enough financial security that I could put my beautiful husband, terminally ill, a lot of cognitive and physical deficits, on an airplane and go to the United States to try to access it. And our care teams, both in Canada and the US, were fully supportive actually of accessing it. But when we were there, we were denied. And we were denied because of being residents of Canada and not residents of the US. And I have heard time and time again of families who are pleading for access, those that can raise the funds, or some of them list their homes to raise their funds to access not only drugs, but these alternate therapies in other locations. It's not just Optune, it's many other, in Europe, there are a lot of other experimental things going on, immunotherapies, that kind of thing. And to put that burden onto patients to carry that torch and to fight, in addition to the fight that is already going on, in addition to some of the information gaps, that's a harsh world. It's a very, very harsh world. But that's why we're here. And so we're here because we need to build a different future. So that question of what can we be doing? One, put patients at the center, start answering their questions when they ask them of you, start sharing the vital information about access, the vital information about reimbursement, those kinds of things, I think is going to be really important. The other thing I want to say is that support for the delivery of care ongoing. We hear time and time again about patients who are being delayed in having their scans and their follow-up scans to know if if their tumors are changing, evolving, what their status is, if they're stable or not. And that is, you know, a stressor that needs to change. Equipment in hospitals, I've learned, isn't always funded. So if we're looking into the future and we're looking for precision medicines, genetic sequencing, those kinds of things, where do the hospitals actually get the funds to make that equipment available, to make progress possible? The standard of care, I want to talk a little bit about the standard of care. So the standard of care in our case was surgery, radiation, chemotherapy, and the specific chemotherapy was temozolomide. In my husband's particular circumstance, his tumor, the genetic mutations of his tumor, made him less responsive to temozolomide, but it was still offered to us. And because it was the only thing on offer, he proceeded with that treatment. It was his choice to proceed with that treatment. But I would argue that this was crushing in terms of the toxicities, in terms of the impacts on him. And we would have done anything to actually at the time gain some sort of access to something else that maybe could have held a bit of promise. And so I think I'll leave it at that for the moment. I'm open to to questions, but just know that access is an issue, equity is an issue, and actually having the pipeline. Actually, I won't leave it there. Let me raise this, and then I'll be quiet. The pipeline to actually bring alternative therapies into Canada is a very difficult one. The barriers to entry are really high. And so that's something that I would really like to see change.
Well, Anita, just on behalf of all of us, I want to say thank you for sharing your personal experience. And I know our hearts go out to you for the loss of your husband and for the 2 anniversaries you've mentioned in the next couple of days. So you mentioned TT fields, and part of this discussion is about new treatments and how we can ensure that Canadians have access. So we'll be coming back to that with our other panelists, and I'll come back to you at the end and maybe just talk to you about Brain Cancer Canada as an organization and some of your current activities. So I'd like to move to Dr. Millar then. Dr. Millar, I guess that the first question here really that people may be wondering about is, what are the current unmet clinical needs for patients who are diagnosed with brain cancer?
So I think all the things I can resonate with what Anita has said. I think it's people are given the diagnosis of glioblastoma has a very limited survival. We have no curative treatments. Treatments are really at the current time looking at trying to improve the patient's quality of life and the length of time before the tumor recurs. And so, as Anita said, like the majority of patients will have this fairly standardized course of treatment, but that wasn't standard until like the early 2000s. Like that was the first, the STOOP study was the first study that actually showed an improvement in survival with the addition of temozolomide to radiation and then adjuvantly. There had been nothing in 40 years. Radiation had been the only course of treatment. So that significantly changed, but did not, it's still far from what we would like for the patients that we see in clinic every week. And so really looking to try and, increase the opportunities for our patients and their families to have quality time, that they can be as functionally capable and do the things they love and enjoy and be with their families is a huge priority. And therefore guiding them to what treatments are and what those side effects and toxicities, and allowing them the ability to choose what's worth it for them. And I think it's hard because our patients and patients in, with any diagnosis now have this internet which shares a lot of information. Some of it is very well collated and thoughtfully put out, some of it is not. And it's enabling them to have resources that they can trust to be able to look for information and for us to be able to share that with them as well. as we move forward. Primary brain cancer with glioblastoma is it is a death sentence. And we need to try and move forward in the treatments that we have to move that forward. And interestingly, there's different correlations that you could think about over time. If we think about the AIDS epidemic, which again initially was a death sentence, and how now people are living very, very long periods of time with controlled disease. And what did they do well? I mean, maybe we can come to that a little bit later, because it's really what we should be looking at is trying to innovate and think outside the box to try and bring our outcomes for our patients in a very different way. I think there are different things out there. They're not always available in Canada. And I'd say, my challenge in clinic every week is that I will have patients and they will ask about many different types of things. And, I will go through what those are and what the evidence is, and, talk to them about whether their family member or whether the patient themselves is actually even well enough to consider that. Because the problem with, a lot of clinical trials is that they're clinical trials and that it's comparing something against the standard of care. And there's always the criteria for patients having to be of an adequate performance status to actually even get entry into those clinical trials, even when there's nothing else that they can have. So that's a big challenge for this particular group of patients, I would say. And I think, the other confusing sometimes is for patients that see primary spread of cancer into the brain, so brain metastasis. That has been revolutionized in many different spheres for different underlying cancers. So you spoke about lung and melanoma. One of the challenges for brain tumors, primary brain tumors, is that most chemotherapy does not get through the blood-brain barrier because the molecules are too large, whereas these smaller targeted agents are now getting in there. So for patients that have a targetable mutation on their lung cancer, we can now use those systemic therapies to actually get into the brain to help control and treat that disease. We're still looking for that within primary brain cancer, and it's still a big problem. And I think, one of our challenges is also the access. We talked about the special models for getting access to new drugs and new agents. And I think things like innovative new technologies like TTF, they fall between the gaps, like the way in which our governmental systems for approving treatments, innovative treatments, if it's not drug, if it's not radiation, where does it fall? So we need to think broader in how we actually look to engage these innovative technologies and innovative treatments, rather than saying, oh no, you don't meet our criteria, we're going to, you have to go and speak to someone else.
I think that's an excellent point, and I wouldn't mind coming back to that a bit later, in particular with our other two panelists as well. But could I just go back, Dr. Millar, and I just wondered if you could talk, tumor treating fields, TT fields, is an example of one of these new treatments. When we think about delays in access in Canada, a lot of us are often focused on the health technology assessment process and what the reimbursement mechanism is in one of the provincial drug plans. Time, right? So time to list, as it's often called. But, both you and Anita have talked about many of these treatments being part of the standard of practice, actually appearing in clinical guidelines in other countries, in other jurisdictions. So if you don't mind me putting you on the spot a bit, what is it like to confront that situation with patients and many patients dealing with a lot and the family, but also very well informed, aware that these treatments are available? In some cases, I assume you're prescribing these treatments, or you would prescribe them, in the event that they were actually funded by the cancer agency. Can you just talk about that from a doctor's point of view?
Yeah, I think it's very hard when you have data, and if we look at the data from the tumor treating fields, the adjuvant study, which actually showed a prolongation of progression-free survival the addition of TTF with temozolomide over temozolomide alone in the adjuvant setting. You know, it's very hard for us to say then, well, actually, we've got approval to use this, but nobody's funding it. And, you know, what is our strategy to deal with that? So, you know, if you think about other things, so we don't have protons in Canada. Okay, we can get protons in the US. So we have to apply to the ministry for special access, giving the clinical details of the case to enable the patient to go to the United States to have proton therapy in specific cases. You know, that's not even set up for patients for TTF. You know, how do we make a case? And it won't be everyone that will step up and say, I want TTF, okay? Because it's a huge commitment. And I'm sure, you know, a lot of people on here will know these patients have to shave their heads. They have to wear an array of transducers on their scalp, at least the EF14 study, which was the adjuvant for TTF plus temozolomide, they showed an improvement if they wore it for over 18 hours. But really what we're recommending is that patients should be with the electrode fields on for at least 22 hours to get maximal benefit from this type of treatment. So it needs commitment from the patient, a change in their appearance, a change in having these transducers on, wearing a battery pack, a change for the family member in that they will have to be that person to be helped with all of that technology as well. So, you know, I think this the challenge is that we have patients who really would benefit from this and who would step up, but it will not be the majority of patients, but we should enable them to have that choice. And that's my challenge in clinic just now.
Thank you. Bob, I'd like to turn to you next. And, you know, you're the co-lead of a coalition that advocates for better access to cancer therapy specifically. And, you know, I wonder if you could give us some perspective on, you know, why we seem to be in this situation in Canada, why there is so much difficulty in accessing some therapies, and maybe if you could speak specifically to hard to treat cancers.
Sure. Well, I think you know, one of the things that comes to mind is that hard to treat cancers and rare cancers often pose a challenge to health technology assessment producers, because submissions for these cancers often rely on phase 2 data or non-randomized trials or trials powered with small patient populations. And the uncertainty that naturally comes with that can often result in HTA producers to frankly not recommend a drug for reimbursement, or to recommend that a phase 3 trial be conducted. Now, there's been some improvement in this area in Canada. You know, Canada's drug agency last year introduced a time-limited reimbursement recommendation category, which aims to provide early access to promising new drugs. In this case, I mean, I know we're talking more than drugs that target unmet needs of people with severe, rare, or hard to treat illnesses. However, eligibility for that pathway requires that a phase 3 trial is being planned. And I think that's a huge problem, because for many rare diseases, a phase 3 trial will often not be pragmatic or even ethical. So I'm hoping, and frankly doing a bit of advocacy, that CDA will amend that criteria in the future. Another challenge for drugs for hard to treat cancers is they're often understandably more expensive than treatments for more common cancers. And typically in Canada, HTA producers have been using the same cost per quality threshold. You know, that's a quality adjusted life year threshold that they apply to other more for drugs for more common cancers. Now, CDA, Canada's drug agency, recently has been applying different thresholds in some assessments. So there is some progress there, but I think from an advocacy perspective, patient groups and clinicians have to definitely do a little bit of work there to try to ensure that treatments for rare and harder to treat cancers are recognized a bit differently from a reimbursement perspective. And lastly, I think there's been no national conversation that I can really see with respect to how Canadians value cancer treatments. Right now, the willingness to pay with respect to cancer treatments is effectively determined by bureaucrats. So I think those are some of the challenges that we have right now and some of the realities that we're living with.
Yeah, those all sound familiar. I mean, I can certainly share that as a Minister of Health, responsible for a provincial drug program. It's a very static, very rigid framework that you've got to work from. And one example of that is that drugs and medical devices go through separate HTA processes. They're not viewed as a treatment in their entirety, and the assessment procedures and the actual reimbursement, the way the money flows, isn't easily open to that kind of a novel treatment. And so that can result in further delays, and in some cases, lack of listing at all as part of a provincial, well, as they're called, drug plans currently. So it's really tough. There's a lot of things I think that need to be addressed to bring us into the future in terms of how we assess and review and fund these therapies, which are here now, and as we've heard, are part of the standard of care in other jurisdictions. So, Bob, I know you wanted I'd love for you to talk about a case study that you have looked at for us. So specifically with this question, if you can apply the case study, what can Canada do to improve its track record on access to cancer treatments? And how can patient organizations and coalitions work with policymakers to ensure that cancers receive the attention and the resources they need?
Sure. So, I mean, I did some work through the CanCertainty Coalition on a drug for a rare cancer known as cholangiocarcinoma. It's a rare type of cancer that forms in the bile ducts. And a few years ago, the manufacturer of that treatment did a submission to Canada's Drug Agency, and it received a negative recommendation. But upon reading the report, I mean, they addressed the uncertainty because of the phase 2 trial. That was a single-arm trial, which is very typical for some of these rare cancers. But what was not clear is that if they applied what is known as the considerations for significant unmet need. Now, that's a loose framework that's built into the procedures for Canada's Drug Agency for assessing drugs. Now, what happened was I was working with a group of physicians who actually did a procedural challenge to Canada's Drug Agency on that particular issue, saying it is not clear to us that you actually reviewed this in recognition that this is an extremely difficult to treat cancer with high unmet need. Now, what happened was that CDA accepted the procedural review, but then a few steps in, they claimed that they did apply the procedure, even though there was no mention of it in their final report. Now, so it stood, the negative recognition stood, but then we started to apply what I would refer to as relentless advocacy. So patient groups and physician groups and individual physicians and individual patients went on a course of constant meetings with policymakers across Canada and policy influencers, including lots of media. And eventually, we got the first province to relent was actually Alberta, where you're from, Fred. And they started providing case-by-case coverage for that treatment, despite a negative recommendation. Then we started applying, the same tactics in Ontario. Ultimately, Ontario kind of collapsed and started providing case-by-case coverage. So then Canada's Drug Agency effectively asked, I would even go so far as to say begged, the manufacturer to do a resubmission, even though the issues that led to a negative recommendation in the first place were not resolved, i.e., a phase 3 trial and things like that. So now we're in the process of, and by the way, Quebec's HTA agency had actually approved funding for this drug. So we now had 3 provinces, leading to massive Canadian inequities in access. So now we're in the midst of another resubmission. I'm quite confident that this will result in a positive recommendation. But this is to really, I think, point out to our audience today that advocacy is hard, but advocacy works or can work, and that I think we really have to constantly hold policymakers' feet to the fire on these matters, particularly on how treatments for rare and hard to treat cancers and other diseases, as Barbara Ann mentioned, are recognized. I mean, we can't use the same lens, across all treatments for all cancer types. I mean, it requires nuance in policy, and when that fails, you have to go hard at it with advocacy. And I think that's what we did to some success. And again, extraordinarily difficult, time consuming, onerous, but sometimes that's what you have to do.
Yeah. Maybe if I can just insert a quick question here for you, and in terms of this case study, but also Dr. Millar. So any idea what the circumstances were, or the considerations were, that would have resulted in the negative recommendation on this? Was it, was it a lack of understanding of the nature of the unmet need? How is it different? Because this is quite a story. Rarely do you see provincial governments putting up their hand to list something that doesn't have a positive recommendation from CDA.
Well, I think in this particular case, there was a huge disconnect between the expert treaters of this disease and their understanding of the data and their understanding of the value of this treatment for a particular subtype of patients that actually had the mutation that this treatment was designed for, and the reviewers. Now, I think this is a fairly consistent challenge that we have, is the expert review committees that exist in these in these bodies, these HTA bodies, don't always consist of people who understand every rare disease or every rare cancer. And of course, the reviewers themselves, the staff at these agencies. I know that they try to bring in experts from the outside occasionally, but I think this one was a significant case where there was a huge disconnect between the knowledge base of the expert treaters and the knowledge base of the HTA review agency. At least that's my assessment of what happened.
Yeah. Dr. Millar, does that ring true for you?
Well, I think the challenge for some of our, like if you think about TTF, they actually got approval, but there's no one stepping up to fund it. So I think that's the challenge. So it's slightly different in that the TTF got CADTH approval, but then at the provincial level, no one, the recommendation is not to take it due to financial on that QALY effect. But this is a relatively rare cancer relative to our lots of lung cancer, breast cancer. So the uptake is a lot smaller and therefore the financial outlay would be a lot less than if it was a generalized, similar to cholangiocarcinoma. That's a rare tumor. It's not going to be lots of people that are going to be suitable for that treatment either. And as I said, even for the patients that might take up different types of treatment, it's not for everyone. So I think that's our challenge. And I do go back to the fact that it's difficult to know who do you advocate to for when it falls between the silos. That's a big challenge.
We'll certainly come back to that at the end. So I'd like to go to to Rodney now, Dr. Ouellette. None of what we're talking about in terms of new treatments is possible without research, and this discussion would be incomplete without talking about the challenges faced at the research level. I think everyone on this call would agree that Canada has some pretty strong research. Rodney, I don't know, to start with, I guess, what do you think the key reasons are that drives this poor performance in pulling through, translating research breakthroughs like the treatment we've been talking about into the adoption of treatments within the health system for patients? So why can't we get the benefit of these breakthroughs to patients? But why are we slow on the uptake?
Very good question, Fred. It's complex. As our panel has mentioned, it's a difficult cancer to treat, but on the research side, it's a difficult cancer to study as well. And I'll mention a few points, biology related, to understand why GBM is so challenging. So it is a cancer that is highly aggressive and infiltrative. So it grows rapidly and invades the surrounding tissue. So even after what appears to be an adequate surgery, oftentimes there's recurrence in a very short time due to the biological nature of the cells themselves. The blood-brain barrier was mentioned. Oftentimes there may be promising drugs that are developed in preclinical models, but the blood-brain barrier just prevents these drugs from being used effectively systemically. GBMs are highly heterogeneous, so oftentimes in one tumor there will be multiple subpopulations of the initial clone itself. So a therapy may work on a subset, but then the others that have changed during development are now resistant to that particular treatment. GBMs themselves are they're very rugged. They have very effective mechanisms like DNA repair, and they will adapt to different contexts. So treatments like chemo and radiation, they may show some benefit, but oftentimes the cells rebound and continues to develop. Another area that's frustrating with GBM is there's such a highly immunosuppressive environment that immunotherapy is not effective as we see in other types of cancer. And compound that with the blood-brain barrier restriction makes immunotherapy not plausible in most, if not all, the cases. So these constellations of features we see in other cancers, but it seems as though they're all there in GBM, which makes it difficult for any one team to address these issues. Compound that with the lack of biomarkers for early detection or predicting which patients may respond to certain therapies, the lack of inadequate models that mimic the actual tumor microenvironment in the brain is another challenge. So it's as if there's all the odds are stacked against GBM patients with all these challenges. But that's not reason to, I guess, give up hope, because if you go back 10, 20 years, other cancers were described as difficult to treat and challenging, and national efforts, collaborative efforts, advocacy have all led to significant improvements in patient outcomes in those cancers. So I would say, if we want success in this area, researchers, I like to say, they're like bees to honey. They will follow the money. So if there is a concerted push by patients, clinicians, researchers to address the issue, that will lead to perhaps strategic funding and national collaborations, I think there we have the recipe to be able to start pecking away at these biological challenges that GBM poses for the research community and obviously for patients.
Thanks. So if I'm understanding it correctly, from a policy or a system change point of view, we need something dedicated in a strategic way to this particular research, and not put it in a position of having to compete with research around other cancers which are not as difficult to treat. Is that fair?
Well, possibly, and I think given the challenges that we've all mentioned, I think Robert and Dr. Millar also spoke to this. We have to have a system that is responsive. I mean, since it is difficult to treat, we need probably an early adoption or a streamlined regulatory process so that these things can be tested rapidly, because as we heard, our windows of opportunity with these patients are very narrow. So we need to expedite these opportunities in clinical trials and the likes.
Yeah. It sounds like networks, and I'm thinking of your comments as well, Bob. It sounds like networks are pretty critical, both from the advocacy point of view and the story that you told, and also from the research point of view. Is that accurate? And what kind of support do networks need to be effective?
Well, I mean, I'm not going to speak to the research networks because that's a little bit out of my area of expertise. But from the advocacy perspective, the networks are crucial because I think Anita would agree that small organizations have very limited capacity and capability to do the advocacy that's often necessary to see successful access to some of these really important new treatment modalities. So you need to work in networks. CanCertainty is kind of part of that network, right? We provide sort of that connectivity and support to smaller organizations. Canadian Cancer Society does that to a certain degree, particularly when it comes to doing submission work for drugs for rare cancers and cancers where there is no representative patient group. They do a lot of work in that particular area. There is sort of an unstructured but recognized network of patient groups, period, in Canada that support each other on advocacy and best practices. So it's absolutely critical, particularly for these diseases with high unmet need. You have that paradoxical reality, whereas it's often for small cancers where there's not a lot of patients and there's not a lot of money to support advocacy and policy work in that area. So you have to absolutely rely on some of the external resources and networking that is available.
Yeah. Rodney, any comment on the subject of networks? And in the research side, I'm also thinking about international networks and collaboration with other jurisdictions. Sounds like those opportunities, as you described, to try things are quite limited. Is in addition to just the funding for the research itself, is networking a consideration in terms of getting in a better position to have the research completed, but also the therapies actually adopted?
It certainly is, and although I don't study GBM per se, I am part of some Canadian networks like Terry Fox, for example, that does translational research. There are groups that are coast to coast that study certain cancers, but it's almost chicken and the egg type of scenario with GBM, and the fact that, as I said before, if the funding is in breast cancer or lung cancer or colorectal cancer, a lot of the researchers will try and seize those opportunities and develop their research programs that may be addressing some of the key points that are also at play when it comes to GBM. So you almost need to create the incentive so that the researchers can start saying, well, my question in immunotherapy may apply to GBM. So you start getting that incremental movement of researchers around the topic. As I said, GBM is complex, so having focused thematics in different areas may be a start, but I think having a multidisciplinary approach to these research questions is vital. And once you get to that point nationally, participating in international consortia would certainly be of benefit, because everybody will benefit from successes that come regardless where they come from.
I think you make a strong case there for some dedicated strategic financial support from government to have that opportunity. We have a couple of questions from participants, and we have a few minutes left, so please, if there's a question that you want to ask, please go ahead and put it in the Q&A box. I'm just going to field a few of these, and then we'll come back to the larger group and talk about moving forward. So this one's for you, Dr. Millar. Why are advocates and organizations so quiet about the absence of proton therapy in Canada? And the questioner is saying Ontario has one of the best referral programs, but they estimate only 6% of patients who would benefit from proton therapy actually get access.
Yeah, it's a big challenge, and we are actively in the process of negotiating with Ontario government to try and bring protons to Ontario. And I don't know why I don't know that we're quiet. I think we're as a community, both for particularly sort of CNS and pediatric oncology, and this is an area which has revolutionized the way in which we can deliver radiation treatment, and reducing the toxicities, particularly when we're treating children, for those longer term toxicities that we know have significant impacts later on. I think we are advocating. I think we've just, perhaps we've not got it on the front of the newspapers all the time, and we are moving forward. And it's a very big expense for the governments, but I think it would, it will revolutionize what we can do for our patients in Canada. Anita, you can probably speak to some of that as well.
I just wanted to give a shout out to the Ben Stelter Foundation in Alberta. They're in Edmonton. They have done extraordinary work, and they are bringing proton therapy to Edmonton and to Alberta. And so this is a major step forward. But while we celebrate that immensely, it also just raises the question, what does this mean? Does that mean that everybody across Canada is now going to be triaged and sent to a single point of delivery? So this is one of those infrastructure questions that needs to be addressed. But I am so grateful to the Ben Stelter Foundation for that.
I don't think the questioner intended to suggest that, you're being deliberately quiet about it. I think it's just something that we don't hear about, and I can attest to that as well. Well, quite honestly, we don't really hear much about hard to treat cancers. So I'm glad we're having this discussion today.
Can I talk to that for a second? I keep putting my hand up. So, I mean, I will say that for the 8 or 9 people a day, like somewhere in there, the statistics, however you want to read at them, let's just say 8 or 9 patients a day that receive a brain cancer diagnosis. The word rare is just very difficult. So I would absolutely prefer that, that we refer to things as hard to treat. It's actually not rare. As soon as you start talking to the community and understanding what people have experienced, it's thousands of people every year in Canada and then globally. And so I just wanted to make sure that we know that rare is a tough one in this conversation, and the use of the word rare can also sometimes stymie the effort, right? Because it comes down to a question of cost, and it comes down to a question of return on investment. But like, you're going to tell me as I'm sitting in the room with my beautiful husband that we're not going to invest in him is kind of what the message gets translated as. And so with Brain Cancer Canada, we're raising funds because the money so far that has been invested is insufficient. It's insufficient against the complexity of this disease, against the urgency of this disease. The research, as was mentioned, needs decades of development and runway time. And then from the point of approval to getting it into clinicians' hands so they can provide it to their patients is additionally lengthy. But this disease doesn't permit that kind of window. We don't have time. It's urgent. And so I think the amplification, conversations like this, the networks, the collaboration, shout out to Canada Drug Agency for involving patients and caregivers now through much more of their effort to look at making recommendations. So bringing those voices in where they're needed. Those are all steps forward, but we need the funding. We need to fundraise. We exist because the funding so far is insufficient, and we recognize just how much more is needed. I had a conversation recently with a director of a cancer institute who said, that we only get funding when we can have a proof of concept. So they have to do 90% of that research and that work, get to a certain threshold, an extremely high threshold in the 90s percentile before they actually get investment. And so Brain Cancer Canada wants to get in front of that. We want to get in, invest in the ideas that might innovate, might drive things forward, might increase access, all of those things.
Yeah, no, thank you. You've got at least one volunteer here, and I won't use names, but there's someone here that has offered their time to advocate for proton therapy, someone that received it, and says that she is extremely good at advocating and would still love to do this. So we can follow up on that after the call. So I want to begin sort of a bit of a wrap up now, and I guess I'm going to ask each panelist in turn. My policy with these things is that the patient/family always has the last word, so I'll come to you at the end, Anita, but maybe I could start with you, Rodney. So just want to know from each panelist, what is the one actionable step that it doesn't mean you can only do one thing, but if you could do one thing that's actionable now, what would that be? It could be in research, it could be in policy or advocacy to make a tangible difference in improving access to care and these treatments.
Yeah, good question. Where to start? I think it's almost concerted. It has to be, a recognition that we can't keep going like this with a disease like GBM, and there's so many good points that have been touched on. I almost don't want to say that we should start with research, but usually answers do start with research. So I think it all comes down perhaps to the advocacy to create the momentum so that we get the funding for the treatments that are promising. We get funding for the research so that the next best treatments come along. So I would say starting with the advocacy and recognizing that this is a problem whose time has come.
Thank you. Excellent point. Dr. Millar, same question to you. What would be your one actionable step that we could undertake right now?
So I think for me, breaking down the silos at the government's agencies that deal with patients with hard to treat tumors, and even the change of name to the Canadian Drug Agency completely denies the fact that there's actually other innovative ways of dealing with cancers other than drugs. Okay, so we need to get out of this mindset. We need to think about how we treat the patient as a whole, not just bits of them that we're giving different types of treatment for. So how do we advocate to kind of break down these silos, get the innovative work that's coming in to be assessed by people who understand the diseases, that really have a clear, it speaks to the discussion of the cholangio case. You need to have people that are dealing with the reality of these individuals. And I think, sorry, this is a second one, so I'm going to push in for a second one, but I think using some of the fast track solutions that they used in different areas to try and get patients into promising areas of technical and drug development to get them access sooner. I think that's going to be I think that's really important given the very finite time window these people have. Enabling them to get access to these things sooner is a big deal.
And just as a follow-up, any thought on who or what organization is best positioned to tackle this silo question? Is it provincial cancer agencies? It should not be the work of patients, their families, and clinicians, certainly. So where should that or could that leadership come from?
I think it needs to come at a national level. But that's our challenge in healthcare is you can negotiate at a national level, but because it's all the money for healthcare is at a provincial basis. But, so you need to have both teams at the same table thinking, how do we do this? And creating a network that is effective because, the provincial teams are looking at their funding as within their buckets, but we need to kind of advocate for that bucket to be a more general, accessible entity for all the different things that are coming through. But I think if we advocate at a national level and then disseminate, I think that would be at least a starting point.
Thanks. About 5 minutes left. Bob, can I go to you now? If you're
Sure. I mean, I guess you're asking, what's the one thing to sort of focus on? I mean, if you're looking for, a new, this new treatment modality, I think, advocacy has to be a major part of the strategy, obviously. And I would tend to try to focus on one province first. I think that a lot of patient groups, when they're advocating for a new treatment, whether it's a drug or a device, often will apply advocacy sort of evenly across the board in every province. And I think you have to try to find one province to fund first, and that could be a matter of assessing your resources, where you have the strongest, physician advocates and where you have the most patients, with the capability. You spoke about one patient, that's online today, and then and assess the viability of a particular province about where there's the opportunity. Maybe they have the least structured silos, whatever it is, but try to find one and then play the other provinces off against that existing province. It's funded in Alberta now. Let's work on Ontario, and then Ontario, you work. I think you have to do this, stepwise and not applying, this sort of evenly across the board. That's my recommendation.
Yeah, well, that was certainly the case study you talked about. There's certainly an example. It strikes me as a former health minister. It's kind of sad that we would have to resort to that, but we do see that as we try to balance, the provincial jurisdiction over healthcare with tackling, large health issues that are new and that are changing and becoming increasingly, treatments are becoming increasingly more personalized. There are more and more of them coming all the time. Hopefully we can reach a point where, and I guess this is where government leadership comes in. We don't have to have the dysfunction of more or less, I guess, as you said, one kind of taking a lead and hoping others will follow. But I've been there and I agree with that tactic completely. So as I promised, Anita, last word to you. You can have more than one if you want.
Because I'm going to, right?
No, you've given us some great ones already, but please go ahead.
I'm never shy to have a conversation. So the first thing I'll say is Brain Cancer Canada looks forward to continuing to raise and investing funds in the research. And today happens to be Giving Tuesday. So a little bit of a plug to anyone that's interested in continuing to support the effort. We will continue to raise money because we need to ensure the researchers can actually pursue these things that need to be pursued. I think looking forward, we're also looking very much to the notion of collaboration and networks and conversations, and those bilateral conversations between the federal government and provincial entities are going to be absolutely critical to this. I think we all have the shared goal, and the shared goal is to make sure that we can change outcomes for patients and families go forward. And so we need to start building conversations with that shared goal in mind and keep them going and see where that might take us. The last thing I'll say is that, and it was mentioned earlier about the information that is available and sort of the scramble that occurs for patients and their caregivers, is that imminently Brain Cancer Canada will be relaunching the website. And in that relaunch, we will have a patient and caregiver section where we aim to provide national and also provincial and territorial resources. So we're hoping that eases some of that burden. Thank you so much for today. Thank you all very much.
Well, thanks to all of you, and we'll look forward to the debut of that website, Anita. So just on behalf of all the participants, thanks to all our panelists for a great discussion. And I'll turn it back to Matt.
Thanks. I don't think any additional words from me are needed. What a fantastic session. So with that, I will say thank you. Have a wonderful day, and we'll talk to everybody soon. Bye-bye.